I'm going to move on to ask the panel to consider transfusion-dependent disorders, and in particular the inherited disorders of hemoglobin. And could I start by asking you perhaps to tell us what hemoglobin is and what these disorders, what problems these disorders generally cause?
Okay. So hemoglobin is the substance in our red blood cells that carries oxygen around the body. And so the hemoglobin, so we need this to obviously provide oxygen. And we have a number of disorders that are very common across the world that affect the amount or the structure of the hemoglobin that circulates in the red blood cells. And these disorders are genetically inherited and probably have arisen over the years because they did confer a certain sort of resistance to malaria. And that's why they're very common in parts of the world where malaria was or is very prevalent. So hemoglobin is carried it's got an iron-containing molecule, and it has these protein chains. And the thalassemias are disorders that affect the production of the protein chains, whereas sickle cell disorders affect the actual type of hemoglobin. So they are different disorders, and they have different clinical consequences. So I'll start with thalassemia. So the thalassemias affect, as I say, the protein component of hemoglobin. They are very prevalent. They are the commonest genetic disorders across the world. They're divided into the alpha thalassemias and the beta thalassemias, depending on which of the protein chains is involved. And the end result is you don't make enough hemoglobin, and this results in anemia, and it results in very small red blood cells. Because of this, there's hundreds of different types of mutation affecting the beta thalassemias, and therefore the very different range of clinical spectrum of anemia and disorders. So the alpha thalassemias are usually not too much of a problem clinically, although in some parts of the world, for instance in South Asia, China, there is a sort of moderately severe form of alpha thalassemia that can require transfusions. But the commonest type of thalassemia we encounter here in the UK is serious thalassemia, or the beta thalassemias. We can divide those thalassemias into those that are severe enough to need blood transfusion and those that don't need blood transfusion. But the genetic basis of this is very complicated, and then really a lot of it depends on the part of the world that you came from, although we see quite a big spread across the UK now. So the problems of thalassemia are related to anemia. If you don't have enough blood cells, you're going to feel very tired. If you're a child and you don't make enough hemoglobin, you're not going to grow and develop. And your bone marrow tries to compensate by expanding. This causes expansion of the bones and causes bone problems and sort of a skeletal enlargement. And it expands by the liver and the spleen expand as well. And generally, if you're a child born with severe thalassemia, you don't grow and survive, and without any kind of blood transfusion treatment, you would typically die in the first decade of life. The other problems that we see are related to the iron overload. So we can treat thalassemia with regular blood transfusions, but each blood transfusion carries with it a certain amount of iron, and the iron our bodies cannot get rid of iron very easily. So the iron is retained by tissues, and the iron particularly is retained in the liver, and it's retained in the heart. It also affects the endocrine glands, and it really affects a number of other organs in the body. So the main iron causes inflammation in excess, and this leads to chronic liver disease, namely liver cirrhosis, and increases the risk of liver cancer. In the heart, excess iron can cause heart failure and heart rhythm disturbances. And excess iron in the endocrine glands causes problems such as diabetes, low thyroid, failure to grow and develop, etc. So the problems are really both due to anemia and iron overload. And there is a sort of mix of both of those, which it varies from individual to individual depending on the type of thalassemia they have and the type of treatment that they have as well. So it's a chronic disorder. People who are transfusion dependent will normally need blood transfusions between every 2 and 6 weeks. And they will need to take treatment really from the first year or so of life with iron chelation treatment. These are drugs that actually remove the iron from the blood. And they will need to attend, so say, for blood transfusions and regular clinic appointments and all sorts of specialist investigations to monitor for the effects of iron overload. So that's sort of thalassemia in a nutshell. Do you want me to proceed with sickle?
No, we'll come on to sickle cell in a few minutes. Just a few further matters arising in relation to thalassemia. There's a national hemoglobinopathy registry.
Yes.
And you've recorded in the report that as of September 2019, the numbers on that registry were 1,921 with thalassemia. Just to complete the figures, for sickle cell, which we'll discuss in a few minutes, 13,675. And then some rare anemias, which we'll also come on to later, 460, although that may be, as I understand it, something of an underestimate. Just in relation to thalassemia, you've also said that those who will require regular blood transfusions is in the region of, I think, 900 to 1,000. And that's a lifelong requirement,
Yes.
is it?
Yes. But many patients who don't require regular transfusions from childhood may start to need transfusions in adult life for a variety of reasons. I think over the years we have tended to lower our threshold for transfusion because we have better drugs to remove iron, and we realise that chronic anemia really is quite disabling for thalassemia patients.
And we know from evidence that we've heard that people with thalassemia who received regular transfusions developed hepatitis C. Is there any data of which you're aware which tells us how many were affected in that way?
No, I think is the answer. I did try and make inquiries just to see whether we had that information, but I don't think we do. The problem is that we have a lot of patients arriving in the UK from abroad who've acquired hepatitis abroad, and we don't therefore know how long they've had it, how they acquired it, and we don't know. We haven't really got reliable data on deaths from sort of iron overload as opposed to other causes of liver disease. So we don't really, in a nutshell, we don't have that information, although we are sort of starting to collect it now.
And you described symptoms associated with either thalassemia or the iron overload, consequences of thalassemia, fatigue and so on, which obviously may be very similar to the symptoms that an individual might experience with hepatitis C. Do you know whether there were problems of delays in people being diagnosed with hepatitis C because they didn't know that their symptoms were attributable or might be attributable to something other than their iron overload?
I don't know for a fact. I would imagine that is the case. Hepatitis C screening of blood only came in the early 1990s. We knew patients had chronic hepatitis, but we didn't know to what extent the iron in the liver was contributing. So it wasn't very clear because there's a number of mechanisms of liver disease in thalassemia.
And the risk of a person with thalassemia and chronic viral hepatitis developing liver cancer is, as I understand it, compounded by the problems of iron overload.
Absolutely, yes.
Which can result in fibrosis, cirrhosis and cancer.
Mm-hmm.
Is there any data about the impact on life expectancy for a hepatitis C positive individual with thalassemia against someone who has thalassemia but no hepatitis?
I don't know of any UK data. I think there will be data from other parts of Europe where hepatitis C is much more prevalent. The life expectancy of thalassemia is changing all the time because we now have much better ways of treating iron overload, and we are much more able to assess more accurately how much iron is in the body through imaging scanning. So we're much better at actually treating iron overload. So we think that our life expectancy for our thalassemia patients is, providing they take the treatment, should be approaching, near normal now. There are other treatments coming on board for thalassemia as well.
That are not transfusion dependent?
Yeah. So there are, we have new drugs in development that will improve the hemoglobin, and we have gene therapy and a new exciting prospect for thalassemia, which is under consideration at the moment.
And then, are there particular difficulties for someone with thalassemia who has hepatitis C or indeed HIV that are compounded, other than the liver consequences we've discussed, that are compounded?
Well, I've never seen a thalassemia patient with HIV. Whenever we get a patient with hepatitis C, and we do still see patients as they arrive from other parts of the world, they are managed with the liver teams, as in the other disorders. The treatment itself can compound the fatigue that they get, and also some of the older treatments used to increase the amount of hemoglobin, so they would end up needing more blood transfusion.
Can I ask you then to turn to sickle cell disorders and tell us a little about those?
Okay.
Can I just
Yes,
comment a bit about a really important part of thalassemia is, as Kate was saying, to get rid of the iron. And until a few years ago, it was mainly injections, subcutaneous injections, which had to be injected at night or during the day, but kept going as a syringe for the best part of 8 hours or so. For young people, it was very difficult. So compliance was very difficult. And going to college or uni or senior school was very difficult. So many of them have now been able to move on to oral chelation, but even that is fraught with a lot of side effects.
Adherence is still a big issue. The drugs themselves are mostly non-toxic, but they need monitoring. But I think with any chronic disease, adherence is an issue for patients.
And the point you've just made adds to the treatment burden for the patient. We've discussed that in other contexts. But if you are a patient with thalassemia who is having also to be treated for the consequences of iron overload and having to receive what we know were horrific treatments in terms of side effects for hepatitis C prior to the modern era of treatment, that can be a significant physical and psychological burden for the individual.
Plus the monthly blood transfusion.
Plus, of course.
There has been some recent study which is looking at the real life experience and it shows that the quality of life is about 65%. If you look at quality of life indicators, it's about 65% for thalassemia patients compared to a normal population, and that's even with safe blood transfusion, reasonably effective chelation. So it is a considerable psychological burden.
And that's before you add the burden of hepatitis C treatment?
Yes.
So sickle cell disorders.
Sickle cell disorders refer to a group of conditions where the basic problem is a genetic mutation in the hemoglobin molecule to produce a substance called hemoglobin S. And hemoglobin S, under certain conditions of low oxygen or other conditions, causes the red cell, precipitates, if you like, in the red cell and deforms the red cell into a characteristic sickle shape. And these deformed red cells are not very pliable. They don't pass through vessels very easily, so they block vessels, and they cause inflammation, and they cause all sorts of problems. Now, the sickling disorders really, we refer to sickle cell disease, which is a number of different types of sickle cell. The most common in the UK is what we call SS, which is about 2/3 of patients, and the rest are SC, SD, a mixture of other genetic problems. The sickle cell gene has arisen in Africa, so most of our patients with sickle cell are of African origin, either Black African, Black British, Black Caribbean, and that's about 2/3 of the patients. The sickle cell gene is also, however, found in the Middle East, parts of Southern Europe, and in parts of India as well. So it's a sort of a disease that affects predominantly sort of non-Caucasians, but increasingly it's seen in all different ethnic groups. So the problems of sickle cell, it's a multi-system disease. Any part of the body can be affected. You can divide the problems into acute problems or chronic problems. So the acute problems, I think the single most difficult problem for patients is episodes of pain, called the painful crisis. These can occur very frequently in some patients and cause excruciating pain in different parts of the body. And often the pain will require strong painkillers, including morphine, and patients need to be hospitalised for pain management. That is very variable. The number of crises an individual gets is very variable. It can be none a year, but most people will get episodes of pain of varying severity, and some patients can be in hospital 20 times a year for a painful crisis. Patients with sickle cell are anemic. They run a hemoglobin a lot lower than a normal hemoglobin, and this can be made worse during a crisis or during an infection. They're very prone to infections as well because the spleen, which is important for processing bugs, doesn't work in sickle cell, so infection, particularly with certain bacteria, is a big problem, and malaria is a big problem as well. And a major problem for children is stroke. So about 10% of sickle children will get an overt stroke, with about another 20% of sickle children getting sort of brain infarcts, which may not be manifest as a sort of an obvious physical disability, but will affect all sorts of cognition and learning and etc. So all these different there are a lot of different acute complications. You can get acute liver problems. You can get a number of problems which require hospitalisation. So that's one aspect of sickle. And during any of those hospitalisations, if you're anemic, or I should have mentioned the chest crisis, is where you sickle in the lungs, and you get a major respiratory failure. So for a lot of these acute problems, you need urgent blood transfusion, which I can come on to in a bit. So many sickle patients will have received, at some point in their life, they will have received blood either, for an emergency indication. That's one side of sickle. And then obviously the other side of sickle is the chronic disease, that management. So with many years of sickling, you get damage to joints. You need joint replacements. You get damage to the heart, lungs, liver, and kidneys, leading to sort of chronic organ damage. And all these things will contribute to an early mortality.
And you've explained in the report that transfusion in this context can be used to correct anemia or reduce the proportion of circulating sickle cells.
Yeah.
So as I understand it, transfusion is not, in contrast to thalassemia, the mainstay of treatment, but it is, as a practical reality, something that many people with sickle cell disease will have undergone on more than one occasion, often on repeat occasions.
So for some of the complications, so we know from a lot of evidence-based studies that if you can predict children who are at risk of stroke, and we can do that now by scanning of the major blood vessels leading to the brain, we can actually identify children who are likely to, or particularly at risk of stroke. We know that if you give them regular blood transfusions, you can prevent that stroke happening. So that is the standard of care in the UK for children. They are screened from about the age of 2, and if they're felt to be at risk of stroke, they are offered transfusions for a period of time. If you've already had a stroke as a child or an adult, that their evidence shows that transfusion is the main treatment to prevent you having a further stroke. So those individuals tend to stay on long-term transfusion programs. Some patients, have been on it for 20 years now. We also, although we have other drugs that we can use to try and help prevent the painful crisis of some of the chest complications, there are a number of individuals who have such bad disease in terms of coming into hospital for pain or other problems that we offer them regular blood transfusion. So at the moment, we probably have somewhere between about 5 to 10% of all our SS patients are on regular blood transfusions. And by that, typically they have a blood transfusion every 4 to 6 weeks, sometimes more often, and we do it in the form of exchange blood transfusions. So that's where you take out blood and you put donated blood back in, and that effectively lowers your sickle percentage. And those numbers are increasing because our patients are getting older, they're getting lung problems, they're getting other indications, and actually blood transfusion makes them feel they don't get pain, they're able to go about their normal lives. So it really, I think our threshold for giving regular blood transfusions is going down all the time.
And in terms of those with sickle cell disease, leaving aside for the moment any question of hepatitis C, what's their life expectancy and how has that changed over the years?
Well, it's changing all the time. We don't really know because actually until recently we've not had a significant number of older patients. We know that you can project across a group of patients. A study from King's in London showed for SS patients a life expectancy maybe of about in the 60s. But that was a group of patients, and that those patients who have the most severe disease are typically living into their 40s still. We have introduced new treatments that we think will impact on children and ultimately adults. And then we don't know what the impact of regular transfusions is. So if you ask me to estimate, I would say it's in the order of the 50s for SS and probably 60s or 70s for the other types of sickle. So on average, about 20 years, less than comparable peers.
Now, given the amount of blood transfusions that many people with sickle cell disease may have received, would you agree it seems likely that there will have been a number of people with sickle cell who received transfusions prior to the early 90s who would have been infected with hepatitis C as a result?
Yes, I would say so. We still have, our patterns of sickle cell in the UK reflect periods of immigration. So we still have a lot of people coming in from Africa, and we still see a lot of hepatitis C acquired in other parts of the world. But I think a lot of the patients who had chronic hep C prior to the 1990s, I think most of those would be probably dead by now. In terms of HIV, I've only seen a couple of patients with HIV, even in patients who've had multiple transfusions from East Africa. So I'm not quite sure what the incidence would have been in HIV, but certainly hepatitis C, I'm sure, yeah.
And what would be the additional effect of hepatitis C upon an individual who has sickle cell disease?
Well, I think it would probably compound the risk of developing chronic liver disease. Now, chronic liver disease in sickle, again, can be multifactorial. It can be related to iron overload from transfusions. It can be related to sickling damage to the liver itself. So I think it would compound the risk of developing chronic liver disease. I also, but like thalassemia, if patients have got hepatitis, they are referred to the liver teams for managing their. So it would again anemia. Because their baseline they're quite anemic. They would need, it would compound the anemia, and they may need the odd transfusion for that.
And as I understand it, there isn't any data as to the numbers of individuals with sickle cell disease who might have been infected through transfusion in the United Kingdom?
No. I mean, I do remember when we did the look back exercise in '94. I worked in a hospital with a big sickle population, and we did encounter a number of patients who had received in blood, but those patients, I mean, most of those patients would not be living now.
Can I then ask you to deal with, or ask you to deal with, the other rare inherited anemias and other conditions in which transfusion would be a significant part or mainstay of treatment, please?
So I'll deal with the latter part first. We use blood transfusion a lot in this country for medical and surgical problems. When people need to have blood transfusions, either because they're not making enough blood or they're losing blood. So this is different from transfusions that are needed for inherited conditions that we've been talking about so far. On the whole, the use of red cells is going down in the UK. On the whole, the use of transfusions for surgery is going down in the UK as compared to transfusions for medical conditions, which is going up. The use of cryoprecipitate is going up in the UK. And so all of these patterns are basically reflective of a few advances in science and practice and policy. So since 2014, there's been a lot of consciousness about using blood sensibly and not overusing blood. And that's across the world, it's called the patient blood management philosophy. And that's been hugely promoted everywhere, including UK. So the use of blood has fallen as people have become more conscious that using less blood is actually okay. There's been very good quality trials since the early 2000s to support that you don't need as much hemoglobin levels to be present in your body through a surgical procedure or even in normal day-to-day life. So previously we would transfuse people so that the hemoglobin levels was around 10, 11 or whatever. And these days we are fairly satisfied with lower levels of hemoglobin. So these have led to improved use of red cells. In conditions where people have severe bleeding, we also use plasma. So that's FFP. And we use cryoprecipitate. So these two have been the mainstream of treatment in inherited bleeding historically. Plasma is still the mainstay of inherited factor V deficiency, but otherwise we've moved on to more improved products. So in people who have severe bleeding like trauma or burst blood vessels or cardiac surgery or liver transplant, it's commonplace to use a combination of red cells, plasma, cryoprecipitate, and platelets. In actual fact, when somebody donates a bag of blood, all of these are included in one bag of blood. But in the UK, they are split into separate units, and when people need it, they're used in combination of packs. And the number of packs that need to be used over time has changed over time. So we used to use lots of red cells and quite little of plasma, and there's been lots of very good quality evidence to say that that ratio should reflect real state of blood circulation. So the more blood we use, the more important it is to use a combination of products so that we don't bleed excessively due to lack of plasma. So these have been the sort of patterns of blood use in the UK the last decade or so. In terms of the outcomes of massive bleeding or major hemorrhages, the improved use and improved availability of blood has made a huge difference to survival. And so lots of statistics have shown that the better quality blood replacement early on in a bleeding patient, the better the outcomes are. And in some sections or in some groups of patients, cryoprecipitate has become a very important part of that treatment. So moving on away from patients who bleed, there is the group of patients who might be anticipated to bleed. So there's a diagnosis of, say, a bowel cancer, and that surgery is likely to lose blood. But you have enough time to make up for the blood while waiting for that operation to happen. So there's lots more emphasis these days on pre-assessment, doing the blood test, treating the anemia before the surgical procedure is done. So again, there's been rationalization of blood use because of improved processes before the operation is done. The second large group of patients who need blood are people whose bone marrow cannot produce blood. And separate from the inherited diseases are conditions like leukemia, where the disease itself interferes with the bone marrow or the treatment interferes with the bone marrow. And such patients are usually dependent on transfusion until the bone marrow can pick up. And so that's usually for a period of 2 or 3 or 4 months while they're on intensive treatment. And the kind of transfusion needs for such a patient would be along the lines of 2 units a week of red cells, some platelets every so often. And because these are related to the bone marrow, it's not so much affecting of plasma or cryo. So these patients are in need of what we call as cellular products, so red blood corpuscles and platelets. Historically, we used to base the amount of red cells and platelets on the figures, so the people will have a blood test every day, know what the platelet counts are, and then we base the transfusion. What's changed in the last 10 years or so is that the thresholds at which we transfuse patients is dropped, so it's now considered safe that we don't transfuse at a certain level, but we transfuse at a much lower level than we used to historically. So again, there's been quite a lot of rationalization in terms of blood use. And overall, UK adherence to such policies within the groups that I'm alluding to is on the whole very good. There's been lots of audits undertaken at individual hospitals, across regions, across the country, which reflect more or less continuous improvement in how blood is used. In terms of the infectious risk of blood, patients who are identified as needing lots of blood, including patients like sickle cell disease and so on, will be vaccinated for hepatitis B vaccine. And so that's much less a problem. In 1999, the UK implemented a procedure called leukodepletion, which basically removes all the white blood corpuscles from the donated blood at source. And because in England and Wales, the National Blood Service is the main provider of blood, this can be done reliably at source. In other countries where you don't have such a centralized system, people would have to buy the filter to be done at the bedside, so it's very variable. But in the UK, it's a very systematic process. And so leukodepletion was done primarily because of the worry about VCJD, but has had a lot of benefits in many other ways and has reduced both the reactions related to transfusions, but also infection risks related to transfusion. There are a couple of other processes which are available for reducing the infection risk, and they're called pathogen inactivation technologies. Some of them are very old, and so, for example, the solvent detergent plasma that's been available for many, many years is one such technology. But for the cellular products, there have been some new technologies, and across the world, they're variably implemented. The commonest technology is to make platelets safer, and the main worry with platelets is more about bacterial infection rather than viral infection. And so pathogen inactivation of platelets is practiced in different countries like Switzerland, Kazakhstan, etc. But in this country, it was assessed by the SAPTO working group, and the existing practice for platelets was thought to be so robust that we don't really need that at the present time. The red cell safety pathogen inactivation is work in progress, and there's a very good trial that was done in Ghana, along with Professor Alain from Cambridge, and that trial established that malaria risk was much reduced by pathogen inactivating. In this country, it's still on a trial basis because, again, our products are deemed sufficiently safe. In terms of inherited hemoglobin.
So the inherited anemias tend to be managed by the same doctors that manage thalassemia because they are conditions where you either don't produce enough red blood cells or you have an abnormal hemoglobin or have a hemolytic anemia where the red cells are broken down. So they're managed in much the same way with transfusions as required for symptoms or specific complications, and they have a tendency to load with iron as well. It should be mentioned that even if you don't have transfusions or you have very infrequent transfusions with both thalassemias and some of these disorders, you can still accumulate significant amounts of iron because of the way the body reutilises the iron and still need to take iron chelation drugs.
I'm going to move on next to the primary immunodeficiency disorders and ask Professor Edgar and Dr. Marshall to address that. So could you tell us again, and perhaps crystallise what some quite complicated science and some names that are definitely beyond my skill of pronunciation, and tell us a little about PIDs.
Okay, so primary immunodeficiencies are a group of conditions where one or other, or indeed several components of the immune system aren't working properly, and that renders affected people vulnerable to infections. The first primary immune deficiencies were described in the 1950s, and the number of these conditions has increased exponentially over that time. There are now probably 400 different conditions. And they affect all age ranges, from newborn infants to people in their older age groups. There's a range of severities, so at the most severe end of the spectrum is a condition called severe combined immune deficiency, where multiple components of the immune system are defective. And that usually presents in the early months of life, and such babies would require stem cell transplantation. At the more mild end of the spectrum, some people will have an isolated deficiency of an immunoglobulin or antibody molecule, which might not even need treatment. But then there's a group of what are called primary antibody deficiencies, which are probably the main group in most of our practices in Europe and the UK, where patients don't make immunoglobulins or antibody molecules effectively, and as a result they're vulnerable particularly to recurrent infections, particularly chest disease. And one of the mainstays of treatment for that group of patients is immunoglobulin replacement, and that's obviously a blood-derived pharmaceutical product. In terms of numbers of affected people, we have a UK national registry, we have European registries, and at present there are about 5,000 people in the UK registered as having a primary immune deficiency, although we know the actual number is probably closer to twice that amount. That's because there's incomplete registration of these patient numbers. And as I say, the most common group of these disorders in the UK would be the primary antibody deficiencies.
And as you say, the long-term treatment with blood products has been a cornerstone of treatment for some types of these primary immunodeficiencies for a number of decades. That's correct. Really, immunoglobulin replacement therapy was commenced when the first case was reported in the 1950s of a young boy who had what was called X-linked agammaglobulinemia. The availability of that treatment has developed over the years. In the 1970s and 80s, immunoglobulin was given by intramuscular injection, which was a very painful process and which resulted in partial correction of immunoglobulin levels. Because of technological advances then in the 1980s and 90s, intravenous immunoglobulin replacement therapy became available, and that was given by infusion routinely once every 3 weeks or so for most patients. Since then, there have been developments in terms of giving immunoglobulin by self-administration, usually subcutaneously. That's not an injection into the vein, but under the skin, usually of the tummy or the thigh, and that can be done by patients independently at home, possibly once a week, that sort of frequency. So those are the main modalities of treatment now. And yes.
If I might add, it's worth noting that immunoglobulin is actually widely used now for non-primary immune deficiency conditions, for a number of secondary immune deficiencies which are caused by other problems such as blood disorder or other blood disorders or cancer, but also for neurological conditions where very high doses of immunoglobulin can be used to prevent inflammation. So the distribution of usage of immunoglobulin now compared to the 80s and 90s is very different. But we've concentrated on the primary antibody deficiencies in all this discussion because that was the group that was treated at the time that this inquiry is interested in.
Yeah, the group that Sara refers to, the secondary antibody deficiencies, that's the fastest area of increase in immunoglobulin use.
And I think you said in your report that immunoglobulin replacement therapy is a human blood product which consists of immunoglobulin extracted from donated plasma, which has been separated from units of blood from thousands of blood donors.
Yeah, that's correct.
And it was first used in the treatment of patients with a primary antibody deficiency in 1952 and in the UK since 1956.
Yes.
Yes.
You've observed in your report you say this, it's always been recognised that there is a risk of the transmission of plasma-borne infectious agents from immunoglobulin replacement therapy, In a review article published in 1957, Pennell suggested that no fraction prepared from pooled plasma by any technique could be presumed to be free from the virus of homologous, you're setting me challenges today, serum hepatitis, unless shown to be so by volunteer studies or by application of effective sterilising technique. One of the questions I've been asked to ask by call participants is just to define what that term is, homologous serum hepatitis.
That was a term that was used back in the 1950s, and that was just a generic term for serum hepatitis, for what we would now call a bloodborne hepatitis. But that just reflects the changes in vocabulary over the time.
And you've identified 3 known outbreaks of hepatitis C infection related to immunoglobulin usage in the United Kingdom. And could you just talk us through those?
Yes, there were a number of... when intravenous immunoglobulin was started to be used, which is in the 1980s, it was noted that there were small groups of patients who presented with either acute hepatitis, which could either be attributed to hepatitis B or to what was then called non-A, non-B hepatitis. The largest group was the last one in 1994, where a cohort of patients, I think it's 36 patients in the UK, but as part of a much larger group of patients in the US, presented with acute hepatitis in the weeks after having a very specific batch of immunoglobulin. We know quite a lot about that episode because it was very studied in great detail at the time. And what we know is that because of the way the patients were being monitored, at that time in the UK it was standard to have liver function tests every 6 weeks. And we know that patients presented with, there were 3 patients who presented with a blip, a slight increase in their liver function tests within weeks of getting this particular batch. What that led the doctors at the time to do was a look back to see what these patients had in common. And it was identified that they had all received immunoglobulin from a specific manufacturer, and that they all, then when they went back in more detail, they could see that it came from a specific batch. So that was a very defined episode. They were all the affected patients were then shown to have the same hepatitis genotype. So it was all tracked back. And that's been the biggest episode that's been described. And we've learned quite a lot about hepatitis C in this group through the study of that group of patients.
And you've said in the report in relation to that 1994 outbreak, 29 of the patients who received this particular product from Baxter Pharmaceutical were found to be hepatitis C positive on 2 or more occasions.
That's correct. And they have subsequently been followed up. Shall I talk a little bit about the natural history of... So in the UK only, there were 36, I think, patients identified as being exposed, of whom 29 had a positive test on more than 2 occasions. When they looked at that cohort of patients 5 years later, they found that 25% of the patients had either got end-stage liver disease or had died with associated liver disease. So much more rapid progression of disease than would be expected in a group of patients with a normal immune system. And I think that people had always recognized that this group of patients was particularly susceptible because their immune system doesn't work very well. But this kind of gave us a measure of just how aggressive hepatitis C could be in this group.
And just the 2 earlier outbreaks that you describe in your report, one was in 1983,
Yes.
and you've said a British-produced plasma product was implicated. And then the second occurred in relation to Scottish product in Scottish patients. Do you know the date of that
That's correct.
second one?
I can give it to you, but it's not on the top of my head.
Thank you, because the report doesn't say. We have a footnote which gives us the date of a paper which may
Yeah, no, I
be the relevant date, but
can
don't know.
give you that.
And you know, again off the top of your head, don't worry if you don't. The numbers, other than it was less than
Small.
the Oxford one.
It was small. I think it was less than 10 in each case.
And has there been any long-term follow-up that you're aware of in relation to either of those two cohorts?
There has been no systematic follow-up of those two cohorts, partly because at the time it was very difficult to identify the non-A, non-B. It was hard to see them as a cohort because there wasn't the same discipline. Sorry.
Yeah, the testing wasn't available.
And the
at that
testing wasn't available.
Because this was at some point in the 80s.
It was early. Yeah.
What's then are there any differences in terms of either natural history, diagnosis and treatment of hepatitis in individuals with primary immune deficiencies?
Yes. I mean, in terms of the natural history, I've already alluded to the fact that this group of patients has particularly aggressive disease, presents much earlier than we would expect. More people develop more severe disease more quickly, to answer that first question about natural history. In terms of diagnosis, because these patients don't make antibody, that's why they're having the immunoglobulin, all the standard antibody-based tests that we would do in patients with a normal immune system don't work. And so the normal immunoassays that we were talking about before or on Wednesday are not applicable in this patient group. And that means that in those early episodes, one might get a falsely negative result because you were using the wrong tests. Once viral load and the PCR-based tests came in, those were the tests that can be used in this patient group, and those are the tests that we continue to use in this patient group. So there is a difference in diagnosis. In terms of treatment, the patients who were affected in the 1993-4 episode, some of them received interferon, and some of them subsequently received interferon ribavirin. Not enough to be able to give a definitive they do better or they do worse. But we do know that in terms of transplantation, this is a patient group who often have other infectious complications because of the nature of their problem. And if you have a chronic infection of any type and undergo a transplant, you're much more likely that that infection will get worse, and that may be life-threatening. So the opportunity for transplantation is not always available for this patient group.
And then, were you able to find any reference to HIV being transmitted to this particular category of patients?
That's a very good question. And in fact, there are no reported cases of HIV associated with immunoglobulin contamination in the literature. And the reason for that is probably because HIV is a retrovirus. It's a different kind of virus to hepatitis C. And it appears that the manufacturing process, the standard first step of the manufacturing process in the preparation of immunoglobulin, destroys the wall of the HIV and so in fact kills the virus.
There are two methods you've described of immunoglobulin being administered, intramuscular and intravenous. And I understand there is a difference in terms of infection with hepatitis through those two routes.
Which is very interesting. Intramuscular immunoglobulin was standard practice until the 1980s. And intramuscular immunoglobulin does not appear to transmit hepatitis C. In contrast, intravenous immunoglobulin has been shown to. Subcutaneous immunoglobulin, which David referred to earlier, which is a often used form of immunoglobulin now, has not been shown to transmit it, but may do. Quite why intramuscular immunoglobulin doesn't and intravenous immunoglobulin does, it's not completely clear. Maybe because the preparations are different. It may be other subtle differences in the way the immune system that is there responds to clearing the virus.
And as I understand it, the reason why intramuscular immunoglobulin is no longer the favoured method of treatment is not because of issues in relation to transmission of hepatitis, but because it's, as you were describing, Professor, it's a more painful and problematic.
And less effective. You don't achieve the same sort of plasma levels that you want to.
And then can you assist with this? What, if any, steps are you aware of that were put in place to try and identify patients affected by viral contaminated immunoglobulin?
Well, I think I might answer that question by describing the steps that were put in place to, rather than doing the look back, but prospectively. When patients are started on immunoglobulin, I'll describe what happens now and then go back. When patients are started on immunoglobulin now, first of all, one would take their consent and advise patients about the risks of the theoretical risk of HIV, of hepatitis B, hepatitis C, variant CJD, and also unknown viruses that and other infectious agents that we don't know about. We would always screen patients for whether or not they had hepatitis or HIV before giving them treatment. And we would then, and test their liver function test as a routine. Patients then undergo regular testing for their liver function every 3 months once they start on treatment. And then once a year, they would, in most centres, or many centres, would have blood stored so that if problems arise in the future, one can then look back and get an idea of when they may have been infected. Now, those, and there are a few other steps that were taken. One is to restrict the product. There are a number of different immunoglobulin products available. And patients, once they were stable on one product, would stay on that product rather than mix and match with many different products. And the idea behind that was to minimise the risk. If you're only having one product, and preferably only having a limited number of batches of that product, your risk is limited. Those steps were put in place in around the 1990s. There was a document which was called the Consensus Document on the Diagnosis and Treatment of Primary Antibody Deficiencies, which was a very influential document. And this laid out exactly what the standard of care was. And in the UK, most of the centres really adhered to that, and these steps were all laid out in that document.
And that was 1994?
That was 1994-5.
You say in your report that since the 1994 outbreak that you've described, there has not, as far as is known, been any further immunoglobulin-associated viral contamination.
In the UK.
In the UK.
Correct.
And that, as I understand, has led to some ongoing discussions about whether you still need to keep samples frozen and whether you still need to have annual screening.
That's correct, yes. I mean, the steps that Sarah's described are widely practiced, but there is now a bit of a debate as to whether we really need to do all of them, because the improvements in product manufacturing processes and the length of time since there's ever been a problem is leading people to kind of challenge that a little bit.
And then can I just go back to something you said a few moments ago, Dr. Marshall, which was about the consent process. Notwithstanding the lack of any further outbreaks or episodes as far as you and your colleagues are aware since 1994, your patients will nonetheless be advised as part of the obtaining of consent process about the risk of viral contamination, including hepatitis B, C, including HIV.
Yes.
Yeah.
What about the possible exposure to VCJD?
Yes.
Yeah.
So that's all part of it.
So there are five. There are the five, which is HIV, hepatitis B, hepatitis C, and now I'm going to forget them. Variant CJD and the unknowns.
And the unknowns. Yeah.
So they're told that.
Yeah.
Will the nature of those risks typically be discussed with them?
Yes, typically. I mean, typically people will be told that there is a risk of getting these viral infections, that these viral infections can be very severe, but that will be tempered. I mean, in this day, at this time, we would be saying it has been a long time, 25 years, since anyone has ever got it through this route. But there are a lot of unknowns, particularly around variant CJD and the viruses we don't know about. And so that would be alluded to. And patients are usually given information sheets so that they can take them home and read them again because the context of a clinic space is not always the best place. So we do always give written material as well that says that.
And would the standard practice be to obtain written consent before undergoing immunoglobulin treatment?
Yes.
Yes. It's possibly also worthwhile commenting that this doesn't all happen in one consultation, because usually when you're seeing somebody and considering immunoglobulin replacement therapy, that will be over a period of time. And there'll be information given over several appointments, and it's often put in the context of a risk-benefit analysis. The benefit is, proposed benefit of immunoglobulin replacement will be to reduce the number of infections the patient's suffering and increase their overall well-being, whereas the potential risk is this theoretical risk of viral transmission. And we'll specifically say to people, there has not been an outbreak in the UK with these products since 1994, and we know that these products have not transmitted these viruses in all that time. But we can't rule out that there will be a new class of viruses in the future that we don't know about. So it's putting it in that risk-benefit context.
And then last question before the break, Sir. Do you think that there may be undiagnosed patients, so patients with primary immunodeficiency disorders who received immunoglobulin replacement therapy in the periods with which we're talking about, who may be infected with hepatitis B or C and be unaware of that, or be unknown to clinical services?
Yeah, I spent a little bit of time thinking about this and as to whether there were affected patients out there who we didn't know about. Patients who are on immunoglobulin because of primary immune deficiencies will generally have severe disease, and it's very unlikely that they will not be under the care of specialist services once they have joined a specialist service. And I think that given that the standard of care that I've just discussed of regular testing for hepatitis C, even in the absence of any known outbreak, means that I think it is very unlikely that we have patients who are currently in the UK with a primary immune deficiency who were infected in the 80s and 90s, who are not known to services.
Yes, I would agree.
Yes.
It's just worth perhaps commenting about the last aspect of the conversation here, which is, so this question of informing people about the risks of any blood product is meant to be across the groups of all transfusion recipients, and the SAPTO guidance specifies what and how. The opportunities to do that is different in different settings.
Yes.
And so the compliance with it varies.
And it's an issue to which the inquiry will undoubtedly be returning in the future, I've no doubt on more than one occasion. So that completes my questions, but I'm conscious core participants may well have questions they want me to ask the panel. So this would be the ideal moment.
Well, shall we? One way we could manage this is perhaps allowing you 10 minutes. You may think you want half an hour, but if you want 10 minutes, then we can take a short 10-minute break, allow that to be done, and then the final few words that have to be said will be said. Or the final few questions asked.
Very happy with that, sir.
So let's take 10 minutes now, and there will be coffee or tea available when we finish, which won't be long after that.
So there are a handful of questions that core participants have asked me to ask. They're primarily, I think, going to be relevant to Dr. Tunstall and Dr. Gooding's areas of expertise because they are in the context of bleeding disorders for the most part. The first is in relation to gene therapy. We talked about current treatments and developments, but in fact I didn't ask you about gene therapy and what might be happening in that regard. Are you able to assist?
Certainly. So gene therapy is an area of very active research in haemophilia at the moment, and there have been some very encouraging studies in both haemophilia and haemophilia A and haemophilia B, with stable levels or stable-ish levels of expression which were coming out for some years. We haven't yet seen a movement into a commercial market It's only in the place of research projects at present. And we don't know if that response will be sustained indefinitely or whether it will be something that will be there for a number of years and then wane from there. So it's certainly something on the horizon. How swiftly it moves from being on the horizon to everyday practice, I don't think we know yet. There were particular... Sorry.
Oh, sorry.
There was a particular barriers for children with the current technologies in that it wouldn't be predicted to work in children due to liver cell turnover at present. But
And the aim of the gene therapy that's the subject of the research you refer to is to have higher lifelong levels of factor, is that right?
I guess potentially lifelong, although whether, a decade or more might be something to look at, yeah.
Can I just add that gene therapy looks very promising for thalassemia, and in fact NICE are considering the use of commissioning of gene therapy in a few months' time for certain groups of patients, and the data suggests that gene therapy gives the vast majority of patients, they become transfusion independent. So it's actually a very promising treatment for thalassemia, and it's under trial for sickle, where again it looks very promising as well.
Then the next question, again relating to the treatment for bleeding disorders, is it correct that very recently, so this month, a decision's been made, at least in relation to England, and not to fund recombinant treatment for VWD and factor 13 deficiency?
I'm not aware what is in the public domain or not for that.
Well, it's sufficiently in the public domain that somebody has given it to me as a question to ask. I am told, and I have no knowledge myself of this, that NHS England's made a decision not to fund recombinant treatment for people with VWD or factor 13 deficiency.
I believe that's the case, yeah.
So that will leave those particular deficiencies reliant in part upon plasma-based treatment, although there's obviously also in relation to VWD, DDAVP, as we've already discussed.
Yes.
Yeah.
Then there's a question, I'm not sure whether you would be able to answer this, but I'm going to ask you and see. So it's the position of people with haemophilia infected with HIV and or hepatitis C. Are there any concerns that antidepressants have had any particular detrimental effect or created side effects for that cohort?
I mean, in theory, there is a potential acquired platelet dysfunction sort of element to some antidepressants, but whether it's a significant effect in terms of haemophilia outcome, I'm not sure. And I would say that it's not something that we would. I think the caveat with prescribing antidepressants for people with bleeding disorders is that they would be used with caution, and typically I think if you were to see a side effect like that, you would pick up on it fairly quickly. It tends to manifest itself with easy bruisability.
Is that the question specifically about antiviral drugs?
I'm afraid I don't know. The question is the question I read out.
So I would agree with Rich about that aspect, but I don't know about the question specifically.
The next question I'm asked to ask you is about the assays. So going back to the question of diagnosis, when it's appropriate to use stage 1 assay and when stage 2 assay?
So there's basically two different ways of doing a factor 8 assay, and they usually give very consistent results. There is sometimes a discrepancy with certain abnormalities in the factor 8 gene that there is a discrepancy. It's not usually a case of being entirely normal on one case and it showing, say, severe haemophilia the other way. It's usually the baseline level changes, or what we would consider the functional level. So it is our practice, we consider it best practice for anyone with a diagnosis of haemophilia to do a two-stage or chromogenic assay. There are also situations where, for monitoring therapy, a chromogenic or two-stage assay is more appropriate.
Again, I'm afraid with the two of you, how does the severity of a person's haemophilia affect the advice you would give them about the activities they should avoid?
I suppose it depends on the. It's a very individualised sort of decision, that I think. You may advise people with a more severe condition that they can participate in certain activities when they feel that they're treated. So if they're on prophylaxis, that would render them safer perhaps than perhaps someone who's a more severe, moderate sort of aspect. So it needs to be very carefully tailored to the patient and what you think their risk is. And also their bleeding phenotype, so not just the numerical levels, but actually how they are themselves. And then the advice then is a negotiation, I suppose, about risk. And I think it's all about trying to present information to a patient and their family about how much they want to do something and what the risks of that might be, and whether they're happy to accept those risks, and if there's anything we can do to modify those risks to enable people. So that's the sort of context, I think, of that sort of advice. But it's not as simple as, just numbers.
And then there's a specific haemophilia B related question. What is Leiden haemophilia B, and what treatment would sufferers be expected to receive and why?
So that's... there you go.
Yeah. I mean, it's one case where we really do see dramatic differences in factor levels that with factor B laden, then we would often see a normalisation or much higher factor 9 levels post-puberty. And so sometimes it's to the extent that you will have usually boys with moderate haemophilia B who may be severely enough affected to require prophylaxis, but then the levels rise with puberty and they may never need to administer treatment again.
In severe haemophilia, what's the average factor 8 level you would aim to achieve? So in severe haemophilia A, is there an average factor 8 level you aim to achieve?
It depends on the context. And when we're saying, if we're talking about prophylaxis or if we're talking about covering for surgery, so these, or after a bleed, and all of these things will be different situations. If we're talking about prophylaxis, we generally don't aim so much on peaks and more on the troughs. So we try to preserve a level. I think most of us are unhappy with a trough that is less than 1 and much happier if the trough is above 3. We may, personally be happier if the trough is 10, but there's a limitations of cost and technologies in achieving that. We don't really know about peaks in prophylaxis, how important they are. And so it's less about aiming for a peak and more about sustaining a trough level.
And again, having the clinical response, the number of bleeds that you're seeing, and the symptomatic joint problems at the same time.
And then on the topic of prophylactic treatment, is the aim to preserve joints or prevent joint damage, preserve life, or both?
Is preserve life as in prevent death or prevent quality?
I'm assuming I think that's what lies behind the question, yes.
I mean, obviously both, but we know, if we have adequate levels to prevent joint damage, then that's going to dramatically reduce the risk of life-threatening bleeding.
And then two slightly broader questions. Again, maybe the panel's able to answer them or not, or that we need to direct them elsewhere. The first is, does hepatitis infection cause immunodeficiency?
doesn't cause primary immunodeficiency, but chronic illness can, by its nature, cause a degree of immunodeficiency. Would you agree with that?
I would agree with that.
Very final question. What pathogens are thought to be transmitted through blood products in the United Kingdom now? And if you don't feel able to answer that, that's fine. But if you do, please do.
We usually counsel for the 5 that Sara alluded to, but every so often there's the blood service would screen for lots of contemporary ones, so that list changes from time to time.
Okay, thank you. Those are the questions. I'm just going to turn my back, see if there's anything vital and pressing. No, I'm happy to say not.
Well, that was indeed the last question, because I have none of my own. It just remains for me to thank you hugely for coming to give your time and your evidence to us. It may have seemed to each pair of you that there has been a form of selective silence at times because of the way in which you have your own particular specialties. But I hope you see how they all fit together and how it was useful for us to present you as a panel dealing with the different conditions that you've dealt with and informed us about so beautifully. So thank you very much. Now, you have something to deal with, I think, but it doesn't require our experts to stay. You're very welcome to stay where you are. That's perfectly happy. You may prefer to sit elsewhere, you may prefer to go, but it's entirely up to you. Ms. Richards.
Yes, sir. So I mentioned on Monday that we had directed some questions to those responsible for decisions about NHS services in the 4 parts of the United Kingdom. And I'm just going to summarise and read shortly from some of the responses that were received. So we asked a slightly wider range of questions than I'm going to deal with now. The first category of questions I'm going to deal with are about hepatitis C, and we asked 2 questions that I'm going to describe. What scans, blood tests and or other checks and or monitoring are or should be offered to a person who's been diagnosed with hepatitis C? How often and over what period of time? Was the first question we asked. And the second, following successful treatment such that the person has received a sustained virological response, what follow-up scans, blood tests and or other checks and or monitoring are or should be offered, how often and over what period of time? So we asked about those the current clinical practice or what should be the current clinical practice and availability of care in that regard. And I'm just going to read briefly what the 4 responses were from the 4 parts of the United Kingdom, because we know from the individual evidence we've heard that on the ground people have not had necessarily a consistent answer from their own treating hospitals and trusts. So the response in relation to Scotland, we had several witness statements from Scotland. These will be published on the inquiry website, hopefully later today, if not early next week. On this particular issue, in fact, the Scottish Government asked Professor Dillon, who you heard from as part of the evidence this week, to provide a response. And the response was this. So in response to the question about scans, blood tests and other checks, he said this: these have changed and continue to change radically and are continually updated in national and international guidelines as new evidence emerges. In summary, a person diagnosed with hepatitis C should have either bloods, liver function tests and full blood count to calculate an FIB4 score or other estimate of fibrosis, or an imaging-based assessment, e.g. FibroScan, to stage their disease. Those who don't have evidence of cirrhosis may be treated, and a blood test obtained at 12 or 24 weeks post-treatment to confirm success and then discharged. Those with evidence of cirrhosis should be treated and remain under 6-monthly review to screen for complications of cirrhosis, in particular hepatocellular carcinoma, with 6-monthly hepatic ultrasounds and estimations of alpha-fetoprotein, and gastrointestinal varices, 3-yearly upper gastrointestinal endoscopy. And then, in response to the question about checks and monitoring following SVR, he effectively already answered, but he said this. Again, this area has changed considerably due to the development of the evidence base, especially around the confidence that SVR is a marker of HCV cure. Thus, the need for long-term follow-up has been removed for most patients. As described above, follow-up depends on the degree of liver damage, those with cirrhosis needing follow-up. And of course, we had a slight amplification of that in the course of his evidence this week. The position in relation to Wales is set out in a statement from Professor Chris Jones, the Deputy Chief Medical Officer, and he said this. It depends somewhat on the patient's circumstances and choice. In general, where possible, the following pathway is followed. Baseline blood tests, including urea and electrolytes, liver function tests, estimated glomerular filtration rate, international normalised ration, full blood count, viral load, genotype and fibroscan performed in a one-stop clinic. Review patient with results, 2 to 4 weeks for results, and medication ordered according to results. Treatment commenced 2 weeks later, delivery time 2 weeks. Review patient early in course of treatment, 2 to 3 weeks after starting, to check patient is tolerating treatment, compliance, repeat routine bloods. Further follow-up at the discretion of the treating clinician in partnership with the patient. Review patient 12 weeks after treatment is finished for blood tests to confirm success of treatment. And then in relation to subsequent follow-up post-SVR, he said this depends on the patient's level of disease prior to treatment. If the patient has no or minimal damage to the liver prior to treatment, then the patient is discharged back into the community as no follow-up is required. If the patient has advanced liver disease, then they would be followed up appropriately by that service, i.e. regular scans for hepatocellular carcinoma and regular monitoring with hepatology. Further later date blood-borne virus testing is also recommended if a patient continues to engage in injecting drug use, so that last bit's not material for present purposes. So that was the position in relation to Wales. Insofar as Northern Ireland is concerned, we have a statement from the Director of Surgery and Specialist Services at Belfast Health and Social Care Trust, Caroline Leonard, and what she has said is this. The hepatology team in Belfast Trust advised that all new patients with a diagnosis of HCV are offered blood tests, and she's listed the various tests, an ultrasound scan and a fibroscan. Those who have chronic hepatitis C and who are fit for treatment are offered treatment if treatment is commenced. Blood tests are carried out during treatment to ensure liver tests remain satisfactory. At the end of treatment, hepatitis C status is checked with HCV PCR test, and again 3 months after completion of treatment. If the PCR test is negative at end of treatment and 3 months post-treatment, this indicates successful clearance of the HCV infection. In previous years, it was also the practice of the regional hepatology team at the Royal Victoria Hospital to do a check-up PCR test 1 year post-treatment. In keeping with practice throughout the UK, this is no longer required. And then in terms of follow-up post-SVR, she says this. The hepatology team in Belfast Trust advised that patients who are PCR negative after treatment and who have a normal fibroscan are discharged from the hepatology clinic. Those who have an indeterminate fibroscan result will usually have a follow-up fibroscan at least 6 months after finishing treatment. If the fibroscan is satisfactory, the patients are discharged. Patients who have a fibroscan suggestive of advanced fibrosis or cirrhosis are kept under long-term review at the liver clinic. These patients require an ultrasound and blood test for alpha-fetoprotein every 6 months to screen for hepatocellular cancer. In addition, such patients have a 6-monthly clinic review. And then to complete the geographical picture, in relation to England, we have a statement of Claire Foreman on behalf of NHS England. And she says, her statement is rather lengthier, and so I'm not going to read out all of it. She refers to what would be the ordinary pattern of HCV care. And then on the issue of what happens post-SVR, she says this. It's generally recommended that in the absence of liver cirrhosis, patients with HCV who have cleared the virus with treatment can be discharged from follow-up and no routine surveillance is indicated. Many clinicians perform a single repeat check of HCV RNA status and liver function 6 to 12 months after treatment to identify the very rare patients who suffer a late relapse. But in the absence of comorbidities, no follow-up is indicated. For patients with cirrhosis, standard follow-up post-therapy should include a review every 6 months with an assessment of liver function by blood tests, including a full blood count, liver function tests, and usually clotting assessment. A liver cancer screen should be performed with an ultrasound scan and an alpha-fetoprotein assessment. And then there's a reference to differential follow-up depending upon comorbidities. So the purpose of highlighting those statements and drawing attention to the fact that they'll be published upon the inquiry's website is precisely because we have heard people relaying that they have not been receiving follow-up care. And whilst obviously the inquiry is not in a position to investigate such individual cases, it's hoped that by asking the question of the 4 nations or parts of the United Kingdom and getting these answers, individuals who feel they have not been receiving the follow-up care that they are maybe entitled to can use this information to go to their treating clinicians or to their GP and ask to have fibroscans, blood tests and the appropriate referrals. So that was the first part of the questions we asked. The second was about psychological counselling and the availability or non-availability of psychological counselling. And I will start, for reasons that may become apparent, with Wales. Again, the statement of Professor Jones, the Deputy Chief Medical Officer. And I should say these are answers to questions that were asked partly about the availability of psychological services generally, and then specifically about the availability of psychological services for those infected with hepatitis or HIV through infected blood or blood products. And the inquiry in particular drew the attention of those to whom the request was directed to a fund set up in relation to provision for physical and mental well-being for victims of the Grenfell disaster, and asked whether there were any similar arrangements in relation to those infected as a result of blood or blood products. This is the position as we understand it to be, or as we're told it is going to be, in Wales. Professor Jones says this: psychological support is provided specifically for beneficiaries of the Welsh Infected Blood Support Scheme through funding provided by the Welsh Government. The Minister announced the provision of this service in March 2019. The Welsh Government, WIBS and Valinja Trust, which hosts WIBS and stakeholders, worked together to produce a blueprint for the psychological services that are required to meet the needs of those infected and or affected together with their families. A proposal was taken to the WIBS governance group and approved. The WIBS Psychological Support Service began seeing beneficiaries and family members in December 2019. The service has continued to develop its standing operating procedures, referral process, etc. All patients who'd previously requested such support were contacted and informed about the service. Those beneficiaries or family members deemed to be of high risk were seen as a priority by either the consultant psychologist or lead counsellor. And then there's a reference to positive feedback. And then this information is provided from the WIBS website. A psychology team specifically for the service has been established. From January 2020, individuals registered with WIBS, their family members and bereaved family members can access psychological assessment and treatment concerning the emotional difficulties of being given and living with a diagnosis of hepatitis C and or HIV. The team are aware of the historical context and have experience of working with the emotional difficulties that have occurred as a result. Our hope is that by offering a specialist psychology service, there'll be some acknowledgement and recognition of the physical and psychological complexity and the impact on quality of life and relationships. So there is a very recently established specialist service for those with whom this inquiry is concerned that has just been set up in Wales. Insofar as Northern Ireland is concerned, we have several statements that will be published, but the only one I'm going to refer to is again from Caroline Leonard at the Belfast Health and Social Care Trust. And she says this: prior to January 2019, no dedicated psychology service was available to either the infected or affected patients or relatives associated with the infected blood inquiry. The Trust established a working group in September 2018 to consider the implications of infected blood inquiry work as this relates to Northern Ireland. At an early stage, the working group identified a requirement for additional psychological support, specifically in respect to the needs of those people in Northern Ireland directly impacted as a consequence of infected blood products. A funding proposal was submitted to the Department of Health, and non-recurrent resources were made available for the Belfast Trust to put in place dedicated clinical psychology capacity to meet these needs. A full-time Band 8A specialist clinical psychologist is currently funded until the end of March 2021. It's anticipated that further recurrent funding to support this service will be considered in due course. The specialist clinical psychologist provides assessment, psychological therapies, liaison and signposting as appropriate for HIV, HBV and HCV infected and affected patients and relatives since January 2019. And she provides a little further information. So again, insofar as Northern Ireland is concerned, it appears that there is some form of specialist service, established a little longer than the Welsh service, but still relatively new, but a specialist focused upon those who've been infected and affected through blood or blood products.
But not specifically mentioning the bereaved.
So the statement, I think, it says infected or affected patients and relatives are referred to in the witness statement. So yes, so it does appear to be broader than infected individuals themselves. The position in Scotland is set out in a witness statement from Samantha Baker. It's quite a detailed statement, and so I'm going to try and summarise it. I hope I'll do so in a way that doesn't do any injustice to it. So she explains in some detail that those infected and affected by infected blood and blood products can access a range of psychological support and treatment, generally as can other individuals within Scotland. So there's the general provision of psychological services as opposed to specialist provision. In response to the question that was asked about whether there was any kind of specialist service or anything equivalent to the steps taken in relation to those affected by the Grenfell Tower fire, the answer was that there's no directly equivalent services in Scotland for people infected or affected in consequence of infected blood or blood products. And she sets out some reasons in that respect, which I won't read, but others will be able to read on the website. She does say that as well as the general services that can be accessed through NHS boards in Scotland, there is a haemophilia psychological support service available for patients with bleeding disorders and their family members. It's said that was initially only available to patients of the Edinburgh Haemophilia Centre, but has been available to patients and family members across all of Scotland since 2018. It's staffed by one full-time psychologist and a part-time psychiatrist. They're based in Edinburgh, but travel on certain days to other Scottish locations. It's available to all those with bleeding disorders and their families. But she says a significant proportion of those using it are infected or family members of someone infected with hepatitis C and or HIV. But obviously that's a bleeding disorder specific service that sits within the haemophilia centre. And then finally, the position in relation to England is again set out in the witness statement of Claire Foreman on behalf of NHS England. Again, she points to the availability of general psychological services that might be available to all members of the community, not specific to the communities with which we're concerned. She says that many patients requiring specialised services for a disease or condition will have psychological support needs at some point in their care or treatment pathway, and responding to psychological support needs can be an important part of a patient's overall care package. Whilst it's not expected or desirable for each specialised service to have their own dedicated psychological support service, it's expected that all services have in place the necessary links and referral pathways. So that's a means of accessing either general psychological services potentially or psychological services that might sit within certain areas of medical practice, but not specifically for infected blood or blood product recipients. And then in response to the question about Grenfell Tower service, well, I'll read out the question that was asked and then the answer. The question that was asked was this. The inquiry understands that A, in October 2018, NHS England announced funding of up to £50 million for a new screening service to be put in place to provide long-term support and treatment for people with physical and mental health issues following the Grenfell Tower fire. And B, a free and confidential NHS service, the Grenfell Health and Wellbeing Service, is available to children and adults affected by the Grenfell Tower fire. Please confirm whether there is any equivalent or similar service in England for people infected or affected in consequence of infected blood or blood products. The short answer to the question is that there isn't any such service in England. There's a longer answer, which in fairness to Ms Foreman is a reasoned answer that's set out in the statement. I'm not going to read all of it out. She talks about NHS England's response to Grenfell Tower being part of its emergency preparedness, resilience and response duties under the Civil Contingencies Act. And then she says this, in the case of Grenfell and other incidents that year, local communities witnessed extreme events likely to result in significant mental health issues as well as other health problems. In recognition of this, NHS England issued advice to health services about caring for affected people shortly after the incidents. This advice encouraged greater vigilance by healthcare professionals and provided a leaflet. Individuals were signposted to use NHS choices. As the inquiry has noted, NHS England announced on the 9th of October 2018 the services it would put in place for the local community affected by the Grenfell Tower fire. These additional arrangements were made as part of NHS England's major incident response in enabling the NHS to return to normal as part of the recovery phase and in response to prevent future deaths report made by the coroner. And she refers to a coroner's report in relation to the Grenfell fire, which noted that many of those affected by the incident suffered emotional trauma and harm and were therefore likely to need appropriate mental health support. And then says this, while services for mental health, including post-traumatic stress disorder and respiratory conditions, are generally available via the NHS for all patients, the services put in place for Grenfell were therefore in response to the specific and additional needs of the Grenfell community. This was consistent with the principle that NHS patients with equal needs should have equal ability to access services regardless of how those needs arose. In the same way, ill patients with hepatitis C have been able to access NHS services and treatments on the basis of need rather than differentially based on how those needs arose. And then she refers to both general and more tailored psychological services being in place for individuals affected by diseases generally through existing networks. So that's the response in relation to England. And as I say, those materials will be published upon the inquiry website, if not today, then early next week.
Thank you, Ms. Richards. This is the time when I have previously, and I will again, reflect on the session of evidence that has just finished and look forward to what comes next. So first, reflection. And you may think it follows on perhaps a little from what's just been said. Last November, at the close of the first set of hearings during which individuals had been infected and affected told their stories, I drew together some of the themes that had been explored. And in particular, I said this, and I make no apology for restating it now. Quote, a repeated theme has been the often unanswered call for help and psychological support for those suddenly facing what has seemed an unfair death sentence, with all its side effects on partners, friends and family, or the grueling courses of treatment they have undergone with their own side effects. It is appropriate, therefore, that when we begin our next set of hearings, remember I was talking then last November, so that's these hearings we've now just finished. We shall hear in particular from experts on social and psychosocial and psychological impact, as well as from experts on hepatitis, HIV, blood and bleeding disorders. This evidence will help place what we have already heard in a wider context and prepare for the hearings with decision makers which will follow. There can be no doubt, let me repeat that, no doubt, that what we have heard this week has underlined that message, written it in bold, set it out again in starkest clarity. It's done more than that. It's added the voices of those who spoke via the intermediaries that we heard on Monday, and putting those voices together with the near 200 who spoke last year directly to those who are here or watching online. More than 250 testimonies have emphasized the need for the message about psychological support to be heard. And I can tell you that I have now read over 4 times that number of written statements, which have in their own individual ways added to the force of what has been said orally. But what makes me raise this again in such strong terms as I do now is that we have now heard that scientific expertise of the highest standing fully supports that view. We shall all take our own messages from this week of evidence. But what I personally would like to highlight is this. It must be the case that anyone who's given a life-threatening diagnosis may need support and should be offered it. And so too their families may need support. Yet the very fact that a number of people with chronic hepatitis B or chronic hepatitis C or HIV infection chose to describe their resulting life-threatening illness and need for treatment to those around them as being cancer rather than hepatitis or HIV shows that the isolation in which they had to bear their illness added a dimension beyond even cancer. Add to that the fact that so many clinicians advised them to tell no one. In effect, medical advice to live a lie, or if that's too strong, at least to limit the social network that might otherwise be there to support those who are suffering. This shows that the stigma of having one or more of these blood-borne infections was not just something the sufferers alone recognized, their doctors did too. Add the sad fact that the evidence suggests that there still remain pockets of ignorance and prejudice amongst, of all people, NHS staff. Add to that the worry. Can I pass it on? Am I infecting those dear to me? Have I already done so? Dare I risk becoming a parent? And then add the effects, the direct effects of the viruses on mind and personality, and the effects of treatment, and if on personality, on relationships. All these factors make it clear that there was a need for there to have been effective, knowledgeable, expert psychological support services on offer. The evidence thus far has underlined that those who received infected blood and their families have suffered in all the ways I've highlighted, and many, probably most, have suffered all the more because they had no such support. Now, I'm delighted to acknowledge the very significant advances that there have been in the treatments for hepatitis, particularly hepatitis C, an HIV infection, and we heard today in thalassemia and sickle cell, and it's anticipated that genetic advances may help further. But what we have also heard this week, however, has told us that though hepatitis C itself can be cured, chronic hepatitis C cannot yet be, nor can HIV. Anyone with either of those conditions must go on taking tablets for the rest of their lives. They may fear what the future brings. Their trust in doctors may be shaky because of the source of their infections. And we have heard that the effects of past infection and past treatment don't simply disappear. A damaged liver does not cease being damaged overnight because the virus that caused it is cleared. personality and mental function may be permanently affected. And we have heard that people are still scared of the way others will react to knowing that they have the disease. Hence, the large take-up of the services of the intermediaries from whom we heard. And some find it difficult to access the medical services they may need for other conditions because they have experienced stigma amongst NHS staff in the past. Now, every day this week, as I've heard it, we have heard the same message that support is needed. Not just from those to whom the intermediaries gave voice, we haven't heard it just from the psychosocial experts, but we've heard it also from leading experts in hepatitis and leading experts in HIV, and today we've heard that psychological support remains at best patchy in some parts of the country. So it's for those reasons that I would like to draw the attention publicly now of NHS England and hospital trusts and boards throughout the country to the fact that the need for specialist treatment by professionals who have a special understanding of infected blood and blood products has not gone away now that there is greater success in treatment of the underlying conditions, that there is a need to ensure that the standards of follow-up of those who have cleared hepatitis C but have been left with a compromised liver are maintained in accordance with those our experts have set out this week. That the support not only of those infected, but their families need special attention, and that those who have lost a partner, son, daughter, brother, sister, mother, father, grandparent, or close friend must not be ignored. I should add that I mentioned NHS England not because I'm being parochial, but because, as you've just heard, both Northern Ireland and Wales have told us that they've started to answer this call by providing services bespoke to those who've been infected by blood and blood products. If they have opened the door to treatment and support, I would hope, indeed expect, to see England and Scotland fully follow suit. Though I've had no detailed dissection of any figures as yet, the evidence thus far suggests that the outlay of public funds would not be great, but also that expenditure on support and screening will save money in the long run because it will help improve and maintain health. The evidence this week from undoubted experts of the highest caliber has demonstrated that the health of the mind affects the health of the body, and the health of the body affects the health of the mind. I hope to be able to acknowledge in the final report that proper support and follow-up will by then be in place across the UK. So much for reflection. Looking forward, what comes next? In June and July this year, we shall start hearing about the knowledge of risk, with particular reference to the haemophilia centres and the clinicians who practiced in those centres. Precise details will follow in due course. This is exactly as I'd anticipated at the start or the end, I should say, of our hearings last October, as I've just read out to you at the start of my reflection. We are on course, as we had planned to be, and I hope you've seen from this week that it fits together to give us a proper basis for approaching what we need to do in June and July, starting then. For those of you who wish to come back and hear that, I look forward to seeing you again. Otherwise, can I just say that I wish you a very safe journey home. Thank you.